Just a quick announcement, we will be starting the webinar in just a few moments while everybody starts logging into the system. Again, will we be starting the webinar in just a few moments? We had a large response of registrants, so we're waiting till everyone logs into the system. I want to welcome everyone to the webinar today and our session on COVID-19 in nursing homes, Calming the Perfect Storm. My name is Lisa Thompson, and I'm the Chief Strategy Officer here at Pathway Health, and we are pleased to offer you this timely and informative session today. I do want to run through a few logistics before we introduce our speakers, as well as while others are starting to log into this, as we've had a very overwhelming registration response to this very timely event. All attendees will be on mute throughout the webinar. The handouts will be sent to all attendees after the webinar concludes, and the presenters will take your questions and will try to answer as many as possible at the end of the session. Please add your questions in the Q&A tab at the bottom of your navigation bar, or you can use the chat box as well. Now, I would like to introduce Susan LaGrange, Director of Education for Pathway Health, who leads our infection control and COVID service lines here for Pathway, and she will introduce our esteemed presenters for today's session.
Thank you so much, Lisa. I am so honored today to be able to introduce our speakers for this presentation. Dr. Joseph Auslander is Professor of Integrated Medical Science and Senior Advisor to the Dean of the Charles E. Schmidt College of Medicine at Florida Atlantic University, or FAU, in Boca Raton, Florida. Dr. Auslander is an internationally recognized geriatrician and is a past president of the American Geriatric Society and serves as the executive editor of the Society's journal. He is co-author of Essentials of Clinical Geriatrics and an editor of Principles of Geriatric Medicine and Gerontology. I would also like to introduce Dr. David Grabowski, PhD, a professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. His research examines the economics of aging with a particular interest in the areas of long-term care and post-acute care. His work also examines the integration and coordination of care for dually eligible beneficiaries. He is a member of the Medicare Payment Advisory Commission, or MedPAC, which is an independent agency established to advise the U.S. Congress on issues affecting the Medicare program. He has also served on several CMS technical expert panels. With this, I welcome both Dr. Auslander and Dr. Grabowski.
Thank you, Lisa and Sue. And it's really a pleasure and honor to be working with Pathway Health. They're wonderful people, and I'm very fortunate to be working with them in several ways. And I'm so glad my colleague and friend, David Grabowski, agreed to join us for this session. we gave a webinar a few months ago. There will be a little bit of repetition, but David and I spent a lot of time over several months trying to update, keep up with all the news and the breaking science, and tried to put this into a paper that has the same title as this webinar, which will be distributed to all the participants. We do have some disclosures. I I developed a program called Interact for nursing homes and had grant funding from several organizations that are listed on this slide. I do serve on some federal committees. I serve on the 5-star technical expert panel with David, as well as the advisory board for Navi Health with David. I do receive royalties from FAU and Pathway Health, and I'm a senior advisor to Pathway Health. You can see David Grabowski's disclosures there, some of which have already been mentioned. He did serve on the President's Coronavirus Commission on Safety and Quality in Nursing Homes, which released its report yesterday. Many of you may be aware of that. So this presentation, as I mentioned, is based on a special article that David and I authored in the Journal of the American Geriatric Society. It's online for free and it will be distributed to all of you. So the objectives of the presentation are to list the elements of what we call the perfect storm. Many people have called several aspects of this pandemic a perfect storm. We started using that term a few months ago. And focused on the nursing home setting, identify multifaceted approaches to calming the perfect storm, and articulate how lessons from the pandemic can help shape nursing home care in the future. I did this in our last webinar. I do it all the time. We have to thank the direct care workers in the nursing home setting. As well as the clinicians. I do go into nursing homes twice a week still, and they are risking their health and the health of their families every day. And where they're working hard, and many will continue to work when staffing is short. We have to pay attention to their concerns and encourage them to stay as healthy as possible. So I'm going to first briefly describe the elements of the perfect storm. First, nursing home residents are generally at high risk for complications of and mortality from COVID-19 disease. That's because they have multiple chronic conditions, and with advanced age, they have altered immune function. In the nursing home setting, most facilities have new admissions coming from acute hospitals who may have acquired the virus in the hospital and can spread it in the facility. And the other thing that's been recognized, we had a couple of people in our facility that were going in and out for dialysis, and I said, well, that's a risk. And there was a recent article that's not referenced, it just was in the last week or two, that in fact shows that residents who are going in and out of the facility for dialysis have a higher risk of acquiring the virus and spreading it. Of course, there's a congregate living setting with high touch care, and there's a high prevalence of dementia, and that causes challenges for social distancing and wearing masks that I'm sure many of you are very familiar with and struggle with. So staff and clinicians come in and out of the facility, and many work at multiple facilities, increasing the risk of acquiring and transmitting the virus. Even screening questions and temperature taking, which may help, but the SARS-CoV-2 infection is asymptomatic. We know this, it's been all over the news, but we've known it for a long time, and 40 to 50% of those infected. So staff and clinicians can unknowingly bring the virus into facilities and transmit it to the vulnerable residents they care for. And More than that, many nursing homes, not all, but many nursing homes are located in communities with a high prevalence of the virus, which we'll show some data is the major factor associated with acquiring the virus in the facility. So David, I think I'll turn it over to you
Sure.
now, and you can, some of the data is from studies that David has actually been involved in as well.
Great. So first, hello, everyone. Thanks for joining us today. And I should note that I really appreciate Joe when he approached me about this paper, I thought it wasn't just a perfect storm. This was a perfect paper to write because it really summarizes a great deal of evidence and gives us some directions forward. So thanks, Joe, for taking me along on this ride. As Joe noted, there are sort of community factors that are associated with spread in a nursing home. And a number of studies have established the point that the reason that COVID is likely to enter a particular nursing home is the surrounding community spread. I often put this very simply. If nursing home is in the community where staff live, it's likely going to get in the nursing home where they work. And this is one of the studies. Joe was involved in this piece. It was led by Betsy White at Brown University. And they partnered with a large national nursing home chain. They had 341 facilities. And you can see that the cases per 100 beds in the facility was highly correlated to the spread in the county of COVID. And in sort of multivariate models, the strongest predictor of whether or not a facility had cases and how many cases was directly related to that community spread. And I'll note one other point. There's a student here at Harvard that even goes further with this point and shows that not only is it related to the local community, but it's actually directly related to where the staff live. The neighborhood where they're located, the characteristics of that neighborhood are going to drive the spread in the nursing home where they work. Next slide, please, Joe. So these are some data I presented as part of a recent Commonwealth Fund brief that just shows the trends here, and it makes a really important point that it's really hard to isolate nursing homes. This is part of why we have this perfect storm. When individuals in the community don't socially distance, when they don't wear masks, this infects staff who then bring it into the nursing home. You just see the trends about 5 to 6 weeks after Memorial Day and all those picnics and get-togethers. You can see those rising trends over the summer and spiking kind of mid to late July. This is the danger, right? If we can't prevent this out in the community, it's going to be really challenging to keep this from entering nursing homes. Next slide, please. So how has the federal government tried to, assist nursing homes? As was mentioned earlier, I was on the federal commission, the President's Commission that just submitted this report to CMS that was released yesterday. One of the things we heard a lot on that commission was just the different guidance providers are getting from the federal government, state government, and then local officials in terms of data collection, in terms of reporting, in terms of guidelines around PPE and testing and everything. It's just really complicated, and that hasn't helped facilities. It's been obvious that facilities have also lacked staff. Joe already mentioned that staff are really the most important resource here for facilities in terms of maintaining good quality of care and good quality of life. We haven't had strong testing capability outside of nursing homes, but this has been magnified within nursing homes in terms of testing staff and residents. And then many facilities nationally have lacked adequate PPE. And one of the findings, and I'll talk more about this finding in a moment, is that the virus is really blind to the quality of the facility. So we've seen it just as likely to enter 5 stars as it is to enter a 1-star facility. Regardless of whether this facility has a history of infection control, we've seen cases. And we have found on the positive side that more staff can actually help prevent larger outbreaks. And so all facilities are susceptible to the virus. It's really based on where they're located, but conditional on having an outbreak, having more staff is really important towards maintaining that outbreak. And I'll show you some additional data on all of these points over the next several slides. Next slide, Joe, please. So I love this slide, and thanks, Joe, for putting this together, because it kind of really sums up where nursing homes are at. They've lacked the ability to test and actually know who has the virus, both among their staff and their residents. So in many respects, they're blindfolded. And then in addition to that, they've lacked the tools that are necessary to really contain the virus. They've lacked personal protective equipment, and in many instances, they've lacked staff. And so they've also had their hands tied behind their back. And I really think that's the perfect way to think about this. Blindfolded, lacking the ability to see who has the virus and who doesn't, and really limited hands tied behind their back in terms of their ability to respond and keep the virus out. Next slide, please. So here was a study on those staffing and PPE shortages that I published with Brian McGarry and Michael Barnett, two colleagues in health affairs recently. And we found that pretty consistently from May through July, roughly 1 in 5 facilities had a severe shortage of personal protective equipment, and 1 in 5 facilities also had a severe shortage of staff. That's completely unacceptable. Once again, these are the exact tools that facilities need to not only maintain good quality of care and good quality of life, but also keep the virus at bay. And one of the more frustrating or disappointing findings that we generated in that study was that facilities with COVID-19 cases among both the residents and staff were more likely to serve more Medicaid recipients, had lower quality scores, and were more likely to be reporting shortages. And so the fact that all of those were correlated is really distressing. Next slide, please. And I've made this point already, but I just wanted to highlight it further, that all facilities are susceptible to the virus. This was a piece I did early on with some colleagues, Hannah Abrams, Lacey Loomer, and Ashvin Gandhi. And what we found using early data from 30 states, is that whether you're a 1-star or 5-star, whether you had a prior infection violation or no violation, you had no statistical difference in terms of having a case or actually the size of the outbreak conditional on a case. All facilities are susceptible. It's really about where you're located, not whether you're a 5-star. And this was true even the share of Medicaid recipients. No difference if you are a high Medicaid home versus a low Medicaid home. Next slide, please. And so I did say that there's one silver lining here in terms of a policy instrument. There are several studies suggesting once the virus is in the building and sort of containing the spread, it's really important that you have staff. Here was a paper by Yui Lee where they focused, he and his co-authors focused just on the state of Connecticut. There's more recent work by Rebecca Gorhes and Tamara Konecka focusing on national data, showing something very similar. Staff matter, both RNs, but also direct caregivers, the certified nurse aides. Facilities with more CNAs, facilities with more RNs have been able to better contain the virus. And that's really important. And I want to connect a couple of dots and then turn this back to Joe. Remember, a lot of facilities nationwide are currently having shortages. So the good news is that facilities with more staff can help contain the virus. The not so good news is that many facilities are really struggling with staff shortages right now. Joe, I'll turn it back to you.
Okay, thanks, David. So one of the things that is a major concern in this perfect storm is the effects of this virus and the disease it causes on residents and families and staff, as well as the injuries. There's a lot of fear. There's a lot of illness and death among nursing home residents. 40 to 50% of the deaths from this disease have occurred in long-term care residents. We all of you, I'm sure, are familiar with the terrible isolation of residents from their families and other loved ones. That is a real conundrum. There's fear, illness, and death among staff and clinicians and their families as well. And there have been regulatory financial and legal consequences for nursing homes as well. This is a very dramatic illustration of what can happen in a nursing home. I saw these data in March, or in March, I think, and in April, I guess. And they make the point that I make the analogy that nursing homes are like a tinderbox waiting to be ignited. And remember, we're far from out of the woods on this. So even though this happened a few months ago, it can keep happening. It just happened in one of the facilities that I'm affiliated with, a 5-star facility. And not this severe, but this is a dramatic illustration of what the tinderbox is like. So when this was a nursing home in Connecticut, and they didn't have a lot of testing capability. They were just starting getting some tests from the state of Connecticut. And on March 29th, they started doing some tests. And, and you can see here in the green, I hope you can see that there are 10 residents with symptoms, okay? And 1 tested positive. This is on one floor, one wing of one floor. 19 days later, less than 3 weeks later, there were 30 deaths in this facility. One person can bring the virus into the facility and do this. And it can keep happening. It's really, really a tragedy. And that's why we can't let our guard down. So with regard to isolation and quarantine, we have to have a very low threshold for isolation and quarantine. Isolate new admissions from the hospital result in many being isolated, which can be especially hard, but regular contact with family and friends should be maintained as well as possible with social media. We can talk about visitation policies. They are essential, but they have to be done carefully. But remember, as I said, it only takes one asymptomatic, well-intentioned person to cause an outbreak. In the facility I'm affiliated with, it was a hospice aide when the contact tracing was done. So those are kind of the elements of the perfect storm. So now we want to talk about how do we calm the perfect storm? And there are several types of strategies that we outlined in this article. The first are public health strategies. The first is maintaining intensive infection prevention and control education and procedures. Second, ongoing screening of all individuals who enter the facility. I know some people think that it's not worth it, but I do think it is. Isolate and quarantine all admissions from the hospital, regardless of test results. Now, there are some new guidance from CDC on this about that I'll allude to. Regular viral testing of staff, clinicians, contractors, and residents, and we have a detailed table in the paper that's still up to date, and I'll talk a little bit about that. And then slow and careful reopening of the nursing homes to visitors. Can't overestimate the importance of infection control, because nursing home residents often do not have typical symptoms and signs of COVID-19, and up to 50% or more have no symptoms. These are residents. And atypical symptoms are common, such as start with a low-grade fever, a dip in PO2 not even below 92%, altered mental or functional status, and GI symptoms. So that's why I say you have to have a low threshold for suspecting COVID-19. Staff may have no symptoms and pass multiple screenings tests and still be infected, and then they can disseminate the virus in the facility. So the only way to prevent infection and further spread of infection is intensive infection control policies procedures, education, and monitoring. And I know that Pathway Health has lots of resources related to that, as there are many other organizations have them as well. So what about testing? This is a very complicated issue, and the tests themselves and the testing recommendations continue to evolve. But whatever test is used, frequent testing of staff and clinicians who come in and out of the facility is essential to prevent future clusters. In areas of high viral positivity, testing at least once per week, or even more often than once per week, in some cases is the safest strategy. Just think about it. We know that someone can work a shift, go home to their usual activities, acquire the virus, and within 48 hours be shedding the virus. And within, so they can be spreading the virus within a few days. So now you all know that the federal government has been distributing point of care antigen tests. And the initial data I saw on them, I guess, were in symptomatic people because I thought they were very sensitive and not very specific. But it turns out that there's reports now that there are false positives, and there are a lot of there's about a 20% false negative rate, and they're actually not approved for screening. So they may be useful. These tests may be useful for symptomatic people to do a quick test, but the gold standard still remains some type of PCR test, I think. And then there's new CDC guidance. So there's a symptom-based strategy for people who have had COVID-19. I think that's appropriate. I haven't seen the actual science. I'm not a virologist, but the new guidance is based on the fact that people who get the virus and have a mild illness stop shedding replication competent virus within about 10 days. And people who get sicker or are immunocompromised stop shedding replication competent virus within 20 days. That's for people who have had the virus. So what I'm uncomfortable with, and I don't know how others who are participating today feel, is that I'm not very comfortable with the symptom-based strategy for those with one negative test or unknown status, because I just don't trust that people could have the virus. So we still try to we don't. In our facility, we're not using that kind of symptom-based strategy for people who have not had COVID-19. And we can talk more about that. Treatment. So one of the things we know in geriatrics as part of the Hippocratic Oath, primum non nocere, first do no harm. There is no evidence-based drug treatment for COVID-19 in nursing home residents. One of the senior nurses that I work with talked to me this week about one of our nutritionists asking to write a cocktail of vitamins and zinc for everyone. And I know there's maybe a little bit of anecdotal evidence that works. There's no evidence of anything that are based on robust clinical trial evidence, certainly in the nursing home situation. And we all know that vaccines are being tested. And there are even tests being done in the nursing home population, but the results of those, despite what you hear, are months away at best. And older people with chronic illnesses do not have the same immune response to vaccines as younger people. Thus, similar to influenza, vaccinating the staff may be much more important than vaccinating residents. So what about some clinical strategies? I talked about this on the last webinar, but I do want to just reinforce these clinical strategies that can help calm the storm. And I'm going to review each one very briefly. So the first is about resident monitoring and clinician visits. Because mention that the symptoms are nonspecific. Assessment of changes in condition should be done every shift. And if you're not doing that, I think you're not adhering to a standard of practice. And any resident with a suspicious change in condition should be immediately isolated until you figure out what's going on. Clinicians should do as many visits as possible over their telephone or telemedicine if it's available. And CMS has changed the rules and made that easier. But I still believe that in-person visits are very important for certain conditions. And then there are tools available to determine what needs immediate and non-immediate clinician intervention and what can be evaluated over the phone or versus in person. So AMDA has a practice guideline on notification. The Interact program has detailed change in condition guidance, and those are available for free through Pathway. Second strategy is medication management and deprescribing. I talked about this before. This was a result of an expert group put together by University of Maryland. Reducing the number of medications, the number of doses, and monitoring parameters will reduce the risk of viral transmission and decrease staff burden and time. There's a lot of drugs being given that don't need to be given. So discontinuation or reduction of unnecessary or minimally beneficial medications and monitoring, changes to medication formulations and dosing regimens to minimize doses and administrations, and appropriate alignment of medication administration times can all be helpful, and everyone should work together, nursing staff with pharmacy staff, with the clinicians, to try and accomplish that as much as possible. In some of the publications, additional publications, there's detailed guidance on what types of medicines you might consider for deprescribing. The other thing that we need to do is take advantage of this pandemic to further advance care planning. The mortality rate from COVID-19 can be high in the nursing home population. And in some residents, unfortunately, clinical deterioration can occur rapidly. Clinicians and staff should therefore conduct advanced care planning discussions and update advanced directives in light of the coronavirus pandemic. And the discussions can actually be focused around just the time of the pandemic. Because if somebody deteriorates rapidly, they're probably going to need to be put on a respirator, and they may not want that. This requires a team approach, and if you have palliative care expertise in the area, it's helpful to engage them. There are many tools to help with this. I really like the website eprognosis.com. That tells you what life expectancy is compared to the time to benefit from certain interventions. Their Interact has a lot of guidance on advanced care planning, but there are really good websites that are listed on this slide. And it's very important to document and communicate these discussions so that if somebody does go to the hospital staff knows what's going on. But if someone decides to have a do not hospital order, I emphasize this, I did it on the last webinar, make sure there's comfort care medicines available, liquid morphine, lorazepam, and atropine in particular. This is a article, it's actually an article about a video that was just published this past week. I have the great fortune to work with Eric Wydera and Alex Smith, who are professors at UCSF. They also work they're in the senior editorial leadership of the Journal of the American Geriatric Society, and they are just brilliant people who are fun to work with. And they published this article about how to conduct a family meeting on behalf of patients with serious illness. And there's a list there that I'm not going to go through of the kinds of things that the steps, and a nice diagram talking about strategies in the meeting. The video is fantastic. It's 16 minutes. It is really well done. I'm going to tell you an anecdote that there's not always time to do this. This was an incredible experience that I'm going to tell you about that happened 2 weeks ago that I'm going to be writing up with the medical students and the residents involved. So I'm teaching post-acute and long-term care now virtually. And the first session we had, we were reviewing 3 patients in a conference room. And I had 4 students on the video on a Zoom meeting. I had 2 residents and the nurse practitioner on it. We reviewed 3 patients. We were about to go see the 3rd one and bring the computer in, and the nurse practitioner was called out of the room, which was unusual. She was called out of the room, and then 2 minutes later, the director of nursing said, I need you to see somebody. It turned out to be the first person we talked about, who is a 90-year-old woman who had been in and out of the hospital for the past 4 months with a variety of illnesses, end-stage heart failure, and she was deteriorating. Her systolic blood pressure was in the low 80s. Her pulse ox was in the low 80s. And I went in the room and she was lethargic. And when I tried to arouse her, all she said was, "Help me, help me, help me." I took her blood pressure myself, and I looked at the director of nursing, and I said, "Who is the responsible party, the decision maker?" She gave me the name. I walked back to the conference room with the nurse practitioner. So I still had 2 residents, 4 students. I called the decision maker, who turned out to be a physician. Actually is the head of an emergency room program. And I told him the situation, and he says, "Well, how fast can you get a palliative care team there?" And I said, "We don't need a palliative care team. We're prepared. We can take care of your mother." He said, "Well, we've been thinking about this. She's had a rough time." And so he said, "Can I conference my sister in?" He was on speakerphone. So now I have the son, the daughter on speakerphone, 4 students, and 2 residents and a nurse practitioner. And right there on the spot, they made the decision to not hospitalize her. And I told them I thought that was the right decision. And I had to do all this paperwork, and we got her a dose of morphine and she calmed down. The next day, the son called me and said, I know this is a hard question. How long do you think she'll live? And I never tell people the answer to that. What I say is, if you ask me if she'll be alive a few months from now, I think she won't be. If you ask me if she'll be alive tomorrow, I don't know. He said, "Well, my sister and I are thinking of coming to see her." And I said, "Well, you're doing the right thing." They came the next day, they saw her, they said goodbye, and she died the next day, comfortably. This was all spontaneous. It was amazing. I said to the medical students, "You'll never forget this." It was an amazing experience. So I'm going to let David finish off by other strategies for the calming the perfect storm. So David, you take it away.
Great, thanks, Joe. And I'll just say I'll go through a few more slides here, and then we're gonna open it up for questions. So please put your questions into the chat and Q&A, and Joe and I will take as many as we can at the end of the talk. So there are a number of additional ways to calm the perfect storm. Clearly, we need to provide facilities with the right resources, especially those facilities in underserved areas. We know that facilities caring for a higher share of Black residents, for example, have had higher rates of COVID and higher rates of COVID fatalities. First and foremost, and I think this has been a big emphasis, and we've already talked a lot about testing, but the federal government is currently providing rapid antigen tests to all nursing homes. The federal government is also requiring testing based on the local community spread. And so we need to make certain that facilities have access to these tests, they know how to use them, and that they've figured out all the local kind of regulatory rule issues as well. PPE has been, as I said earlier, a real gap in sort of our response to COVID in nursing homes. Once again, 1 in 5 facilities have a severe shortage. We need to make certain facilities have PPE. Staffing, we've also seen staffing shortages now, and we need to figure out ways to plan for when staff get sick. How do we have backup staff here? How do we make certain the staff can stay home and they're not having to go into the nursing home when they're symptomatic or asymptomatic when they're shedding the virus. One of the big issues here has been communication. There's been a lot of gaps in terms of communicating between facilities and families, and sharing resources as well between nursing homes and local hospitals and health systems. And so all of that needs to be improved. And then finally, there's been a lot of issues around quarantining residents as they come from the hospital and creating kind of specialized COVID units or facilities. And that's obviously something that can really help in terms of preventing the spread. I think we can be pretty firm in saying COVID positive patients should not be just discharged to any nursing home, that the nursing home should have the capability to do that care safely. Next slide, Joe. So Joe and I also outlined a series of different policy strategies in our piece, and obviously I'll come back to the one I noted earlier about this misalignment of the rules at the different levels. That's a pretty obvious one. We also need to make certain these rules are well tailored to the nursing home population, and that we're giving all facilities the resources and not punishing those facilities that may be in an area where there was a particularly high spread, for example, in the community of the virus. We know there's been regular updating of CMS waivers and rules. For example, the 3-day rule has been waived in nursing homes to sort of help nursing homes, if a patient needs to be discharged from the hospital and the nursing home can safely care for them, let's not let the 3-day rule, for example, be a barrier here. Obviously, telemedicine is going to be an important part of this. We want to keep the survey process consistent, and I think we don't necessarily want to punish facilities for having cases. As I said earlier, cases are a function of that community spread, and really helping facilities to fight this virus, but not trying to unduly punish them for having cases. And then this last one is controversial. Joe and I aren't saying that facilities get a full liability shield, but what we're trying to say here is that we shouldn't, given the pathways we know towards facilities having COVID cases, unless there were repeated violations or negligent care, simply having a case isn't a reason for a massive sort of legal case here against a facility. So I think that's something that's really important, and really being clear on that point. Next slide, Joe. This was a piece that I published. Ann Tumlinson led this, and we published in JAGS again. And we just tried to think about the roadmap out of COVID. And I imagine we want to try, as I was reviewing the slides for this, I was trying to place what stage we're in. And I think we're in stage 2 right now. And my fear, and it sounds like I share the same fear as Joe, is that this fall, we don't know what we're facing, and we might be back in stage 1 in terms of the surge. So, but I think for the time being, we sort of survived the surge, and we're in this stage 2 of regrouping and preparing and protecting. And I'd love to see us transition as we move out of this to recovery and thinking about once we have a vaccine in place in that 3rd stage and distributing that. And then that stage 4 is really kind of the longer term, how do we make certain that everything that we've learned through this pandemic is actually implemented going forward in nursing homes and other post-acute care settings. Next slide, Joe. So finally, this was a piece once again that I published just last month it's a Commonwealth Fund brief, and these are some bigger picture issues that I really targeted towards reshaping the future. This is I guess it would align with stage 4 in that prior slide of how do we actually strengthen nursing homes. One of my colleagues called COVID a crisis on top of a crisis, and I really like that we need to get out of this immediate crisis of the pandemic, but we also need to address those longer term issues that the nursing home sector has faced. And we know we need to fix payment. Medicaid is a historically poor payer of services, and we need to fix that. We need to get more clinicians like Joe Auslander on site in these buildings. We need to make certain our direct caregivers are getting paid a living wage, and we want to put dollars in their pocket, and we need to make certain there's enough of those direct caregivers in the building. We want quality to be more transparent. Joe and I are both on the technical expert panel at CMS that helps with Nursing Home Compare. We think we've made some improvements to that tool over the years, but I think we have a long ways to go in terms of approximating what all of us think of as a good quality nursing home. We could spend a whole session on regulation, but I think it's safe to say we need to improve both enforcement and oversight, but also the idea that the regulation is actually leading to quality improvement. I'm a big fan of different small home models and those that are very resident and person centered. I'll use one example, but there are lots of good examples. This would be the greenhouse, but I think there's a lot of those good examples. Obviously, we want to keep individuals out of nursing homes if we can, and we want to invest in home and community-based care. And finally, we'll see if this happens, but I'm getting to hear more and more talk about a national long-term care benefit, and it'll be really interesting from a political standpoint to see how this plays out in the coming months. Next slide, Joe. So that's our presentation. Maybe at this point we'll open it up to questions, comments, and suggestions. And Lisa, I don't know how you want us to take on these questions. I guess we could just go in order, or do you want to direct us to certain ones? Either way could work.
Well, how about this? I do have the listing of all the questions here, and thank you everyone for your very keen insight. And again, thank you, Dr. Auslander and Dr. Grabowski, for this wonderful presentation. And again, a reminder to everyone that we will be sending out the handouts as well as a link to the recording of this presentation to everyone after the conclusion of the webinar. So the first question that we have here for Dr. Grabowski, it's related to your experience with the commission that just released their report. Do you feel that there is truly any recognition of the reality that declining reimbursement has a direct impact on the facility's ability to staff as desired?
Yeah, so we spent a lot of time as a commission talking about the staffing shortages, and this is one of those areas where we were really focused on how do we get out of this pandemic. But I think this comes back to this crisis on top of a crisis that in the longer term, it's really hard to fix a lot of the problems around COVID if we don't fix some of these long-standing issues. And so my hope is that one of the outcomes of this will be sort of a broader sort of analysis of whether this model is working. And I can tell you, I don't think it's working at all. We overpay on short stay, underpay on Medicaid, and sort of hope it works out. And COVID has really exposed how flawed that thinking and that model is. And so I completely agree that this wasn't a high resource setting to begin with. And to expect facilities to be able to do this without kind of more Medicaid resources was unrealistic. And so I hope going forward, Lisa, that this is one of the areas we can really address.
Absolutely. There's some questions here as it relates to testing. And one of the questions here is, what is your opinion of the BD Verter, the PLUS system for rapid detection of SARS-CoV-2, and really what the current testing outcomes have been? Do either of you have a thought or comments in relationship to that?
Lisa, is that one of the antigen tests?
Yes, it is.
Well, as I said, when I drilled down and looked at the data that I could find, the the tests had like over a 95% specificity, meaning very low false positive rate, and an 80% sensitivity, which means a 20% false negative rate. But I think that all those data come from small numbers of people, and I think that was in symptomatic people. So I was on a call with one of the organizations I work with, and apparently, and this was also said by Dave Gifford, and I believe everything that Dave Gifford says. He's a wonderful person, and there apparently have been facilities that have had high false positive rates with the antigen tests. I have no idea how that happens. So, and the false negative rate is there. So what our organization is thinking about doing is using them for symptomatic people. So for example, if someone during the flu season gets symptoms of a respiratory illness, we could do we have rapid flu test capability and one of the antigen tests, and we can go from there. But for screening, I'm not sure they're as helpful as they were hoped to be. I don't know if, David, you have other information.
Yeah, I sort of think of the antigen-based tests as like a nice part of our toolkit. We know the PCR-based tests have taken too long. We can't rely on 3, 5, 7 days to wait for tests. So I think, Joe, I like, you know, if we do this rapid testing, we do enough of it, I think balancing that with sort of following up with PCR-based tests, and just, I think it can be a part of our toolkit, but the rollout here is, I would acknowledge, been really bumpy.
Okay. We have another question here in relationship. Do you have an opinion on the lack of qualified infection preventionists in healthcare setting? Does that contribute to the outcomes and the mortality rates that we're seeing right now?
Yeah, I could start, Joe, quickly. I think that this was an area we focused on in the commission, absolutely requiring a full-time infection preventionist. I think that's a good move, and I think that would have helped here had we had that in place. It wouldn't have stopped this. Obviously, it's not the only solution, but I think it could have been a part of our prevention efforts.
And I think this is important for the future.
Yeah.
I might not be on the green side of the grass when this happens, but there'll be other pandemics, and you just have to be prepared to avoid the tragedies that we've seen in this one.
Absolutely. We do have quite a few questions here. We do have a question that's really a larger question. It says, do you see the role of nursing homes changing in this new normal and moving forward here?
I'll let David answer that one. I have some thoughts, but David's the world's expert on this. So.
Yeah, I do think we're going to see a different role for nursing homes, and two parts of that. The first is we're seeing, you know, occupancy fall tremendously. I think it's down 100,000 individuals since January 1st of this year, and the question is, will those individuals come back, and, you know, if so, how quickly? And I think many of us, you know, there's always going to be a role for nursing homes, but I think we're going to see more individuals interested than ever before in home and community-based options. And then I think with nursing homes, I really think, once again, focusing on some different models within nursing homes. And I'll point once again towards those small home models. They fared really well through the pandemic. They have fewer staff coming in and out of the building. Oftentimes they have consistent assignment, and even in high spread areas, smaller homes have kept the virus out and kept, you know, cases down. So I really hope it you know, not just that smaller homes are providing better quality of life, but maybe they're naturally better at infection control. And so my hope is that we're seeing a more robust option of home and community-based services, coupled with kind of a reimagining of what a nursing home might be, and kind of a smaller, more person-centered, more staff-directed, and paying staff a living wage. That's my hope, Lisa. It's kind of that big vision. And I know if someone was able to ask a follow-up question, it would be, well, that costs money, and 100%. We need to pay for that, because that model is more expensive.
I'll just add a couple comments. I think, you know, we do have to have some mechanism for people to save over their lifetime for long-term care needs. It can't be all the government's responsibility. But I just want to quote my late mentor, Bob Kane, who I worked closely with for many years. And he always said that the term not nursing home is an oxymoron. There isn't enough nursing staff, and it's not like a home. And that relates to in fact, one point I want to make is I don't think all nursing homes, whether they're small or big, should be doing post-acute care. And they're forced to now. It's the financial model that David alluded to. I think some nursing homes should be, you know, small greenhouse-like nursing homes that take care of long-stay residents, you know, attending to the clinical needs that they have. And some should more focus on the sicker people and have the expertise to do that. And so I'm an advocate for thinking about it like that, because, you know, they're very, very different populations.
It's interesting, Joe, and I'll just add on to, I'm going to keep going and going here, but I love this idea, Joe, you're advancing of the separation of post-acute and long-term care, why those are bundled. And I realize there's economic reasons, and there may be some spillovers from the staff, and there's some economies there, but there's no reason those have to be bundled. And I think it's actually prevented, Joe, that long stay group of residents from, you know, truly having a home, and that it's a more clinical environment, more institutional environment, and those two could be completely pulled apart.
And on the flip side of that, I'll just make one more comment. For the post-acute patients, it's disturbing to be in an environment where you're taking care of people that have severe cognitive impairment and they have behavioral symptoms. So, you know, those are the key reasons I think like that.
Definitely.
We do have quite a few questions and comments related to the most recent CMS guidance that came out on visitation and reopening of nursing homes. Can both of you comment on that and your thoughts and how truly nursing homes should look at this guidance and proceed?
Go ahead, David.
Yeah, so I did a Washington Post op-ed several weeks ago with a couple of colleagues, and we suggested that we needed to rethink our policies here. I think not only has the virus killed a lot of older adults, but isolation and loneliness have killed a lot of older adults. And I was very much on board early on in the pandemic of, you know, protecting, you know, all the residents, you know, really locking down these facilities. But over time, it's clear we've swung the pendulum too far to the safety side, and we need to bring it back to resident quality of life and resident dignity. And so finding that right balance is important. So I like the guidance that, once again, we're moving towards greater visitation. In our Washington Post piece, we talked about, you know, essential care partners and playing a role in the care there. And I think it's good for the health of the residents to have their family members there, to have them playing a role in their lives. So I like kind of the reopening, but I appreciate it's not an easy measure for facilities. It's time for the facilities, and there's risk there. And so how do we do this safely? And it goes back to some of the same things that Joe and I wrote about in this piece and talked about today: testing, PPE, and there's ways to do this safely.
Yeah, I agree. I was, when I did the first webinar on this, I was very much saying, you know, be careful about opening up to visitation. But I think it's very clear that I think what David said is right. And there are just too many downsides to not having visitation with appropriate policies and procedures in place to not do it.
And I know we do have a lot of questions here, and what I will do is I'll compile these questions and get it back to the panelists here. The one last comment then was from some of the attendees is saying, well, yes, we have this great guidance, but, you know, unfortunately how it happens in the regulatory world, and as we're dealing with these unprecedented times, the guidance came out, says it's effective immediately, and then put forth sanctions on top of it right away, instead of it being a collaborative approach, which I do believe we all agree that it should be a collaborative approach and do the right things. But and I think all providers want to reopen their homes, but do it safely and do it the right way. So, again, we want to thank everyone for joining us today. Our team will put together and compile additional questions, and we'll work with Dr. Joe and Dr. David on this to get some answers to those questions. It has been a very informative and very timely presentation today. And again, thank you, Dr. Auslander, Dr. Grabowski, for your keen insight, your research, and for always looking after the resident safety, our associate safety, and also protecting all of us as leaders in post-acute care. We can't thank you enough.
Well, thanks for the opportunity, and thanks for everybody for attending, and special thanks to David as well.
Yeah, thanks, Joe, and thanks everyone today, and be safe out there.
Thank you all.